gastrointestinal and urologic emergencies. When we are looking at gastrointestinal emergencies, the chief complaint gonna be abdominal pain. Again, a whole range of things can cause abdominal pain. Therefore, it's not for us to identify exact cause, but is to treat what is presented to us. So abdominal pain is a common complaint. Cause of this pain is often difficult to identify. As an AEMT, you do not need to determine exact cause. What you should be able to do is to recognize a life-threatening problem and act swiftly in response. So you will assess rapidly and provide emotional support. Again, in these emergencies, the person will need definitive care, surgical intervention, diagnostic tests to actually determine the cause, and then they will be able to deal with it in that definitive manner. So our job again is to provide that supportive care, manage their ABCs, and package and transport them appropriately. Again, any system you are looking at in terms of emergencies, you have to first have a knowledge of the anatomy and physiology. Again, you would have looked at these in your human body chapter, and also we just basically doing a quick review. So the abdominal cavity contains solid and hollow organs that make up the GI, gastrointestinal, genital, and urinary system. And when we talk about the gastrointestinal system, we're talking about that alimentary canal that runs from your mouth to your anus, and it involves in digestion. So all the organs that along that pathway involving digestion would be a part of your gastrointestinal system. So an injury to a solid organ can cause shock and bleeding, because these are structures that are vascular, highly vascular. And so you will have bleeding, which can result in shock. And these solid organs, which would be in the gastrointestinal system, would be your or the abdominal cavity per se, would be your liver, spleen, pancreas, kidneys, and ovaries. These are the solid organs we are looking at, and the abdominal cavity topographically would be divided into quadrants. So you need to have landmarks that you can identify. You need to know where these organs are in relation to the different quadrants. So once there's a problem and the person is having that abdominal pain, based on where they're having it, you can have an idea of what underlying structure would be impacted or potentially compromised. So we say that the gastrointestinal system, also known as the digestive tract, because it involves digestion, and it consists of mouth and many organs. So all of that passage from your mouth to your anus would be the digestive or alimentary canal, digestive tract or alimentary canal. And so we said there are solid organs. You need to know their positions, and we say you use the general landmark of your umbilicus is divided with a perpendicular line through it, a horizontal and a vertical line, and that dissect that abdomen into 4 quadrants. So you have upper quadrant, left and right, lower quadrant, left and right. And remember that when you say left and right, it is the patient's left and right, not you, the provider, as you are looking at the patient. Because my right looking at the patient would be the patient's left. So remember that it's the patient's position we are talking about. And so know the different quadrants, and you have to have an idea of what structures fall in which quadrant, so you can have an idea when you are doing your assessment what structures are affected based on the patient's presentation. So you have solid organs and you have hollow organs. So the hollow organs you'll be looking at would be, if you look at the quadrants, it would be the gallbladder in the left, the right upper quadrant. Also, you'd have the ureter and the large intestine, portion of the large intestine would be in that quadrant. The fallopian tube, urinary bladder are other hollow organs, and you have the stomach, small intestine, uterus. These are the hollow organs that you would have in that abdominal cavity. Again, we said this is review. So the entire digestion process takes 8 to 72 hours. So that's about 1/3 day to 3 days. Salivary glands secrete saliva to help lubricate the food. So the first process of digestion starts with the food being secreted with saliva and lubricated, and you would chew the food first and start the breakdown process, and so that first process starts in the mouth. Once food is swallowed, it moves through the esophagus, and we know that the medical term is esophagus. The layman term is gullet, and that's where it falls. It moves from the mouth through the esophagus, and then it's gonna enter the stomach. But recognize that intertwined around the esophagus are veins that drain into a more complex series of veins, which join together to form the portal vein, and these go to the liver, which form. So have that idea there, and like I said, this is review. From the esophagus, the food moves to the stomach, and this is where the most of the digestion takes place. It's broken down into what we call a chyme. So the rhythmic contraction of the stomach, and you have hydrochloric acid breaks down the food into a structure we'd call a consistency that you would call chyme, and this is what can allow it to move into the small intestine. So recognize that the stomach can stretch many times beyond its normal size, and the stomach absorbs some material. So some absorption of material takes place at the stomach, but main thing is that it causes the digestion or breakdown of the food to that chyme consistency where it can move to the small intestine. So after leaving the stomach, the food is gonna move to, in the chyme form, gonna move to the first part of the small intestine, which is the duodenum. And here is where most absorbs resources for use by other cells. So a lot of absorption is gonna take place here, and so that is where you have the breaking down process, so you can move to a consistency where the cells can use it. First part of small intestine, where pancreas, liver, and gallbladder connect to digestive system. So enzymes are released here to aid in the digestive process, and you have amylase breaks down the starches into sugar. So the starch, the protein, the fats are broken down here and absorbed into the bloodstream, so that can go to the different cells. So the purpose of the liver is to assist in digestion by secreting bile, and we know that the bile is what's gonna be used to break down the fats, and the bile is stored in the gallbladder, and from there it moves through the bile duct to the gastric tract. So the liver also filters toxic substances produced by digestion, and it also creates glucose stores. So the liver is very important organ, very important organ. Another section of the small intestine will be the, after the duodenum is gonna be the jejunum, and the last portion will be the ileum. So we have the consistency of the food moving from the stomach will be chyme, and in that it can be absorbed by the capillaries of the small intestine. So most of the absorption of the nutrients gonna be done in the small intestine, and we say it started in the duodenum and continues through the jejunum and the smaller portion in the ileum. Once the nutrients are absorbed from the small intestine, then what is left is waste, and that's what is now feces. So the large intestine, now we're gonna collect this feces, and you have absorption of water takes place, and it's gonna be basically solidified. And this is where you have the site of bacterial digestion. This is what gives rise to our flatulence. So you have gas, bacteria digested, and you have gas form, and that's what you have the flatulence. Additional abdominal organs, not really a part of the digestive system, but it's in that abdominal cavity. And so you have spleen is also located in abdomen, but has no digestive system function. It's part of the lymphatic system, and what it does is assist in the filtration of blood. It also aids in the development of red blood cells and serves as a blood reservoir, and it produces white blood cells to help the body fight off disease and infection. So it plays a very important role. It's very vascular, and you need to recognize that it's there, and it can promote significant blood loss, hemorrhaging, if it is ruptured. A part of another system that is inside of the abdomen is the genital system, and you will see where the genital system holds the abdomen, also holds the reproductive organs, and for the female it would be the ovaries, fallopian tubes, uterus, cervix, vagina, and for the male it's gonna be the testicles, epididymis, vas deferential, and seminal vesicles, prostate gland, penis. These are genital system. They are housed also in the abdominal cavity, so it will affect, it can lead to problem with these. This system can also give rise to abdominal pain, and so you need to recognize this also. Another system that we find their structures involved in the abdominal cavity, the urinary system. So the main digestive tract is the in the peritoneal space, but these are in the retroperitoneal space. They are behind the peritoneum. So the urinary system, it consists of the kidneys, the urinary bladder, and this is where the urine is stored. From the kidney, you have tracts or tubes that are transporting the urine called ureters, and they transport the urine from the kidney to the bladder, and then from the bladder to the outside is the tract would be called urethra. So there's a difference. Make sure you know the difference. Ureter is from the kidney to the urinary bladder, while the urethra is from the urinary bladder to the outside of the body. And thing to note here also is that the urethra in male is longer than female, and that's why female will have more easily contract urinary tract infections because of the shorter urethra. So as it relates to the urinary system, two main functions. It's gonna be there to regulate electrolytes, water content, and acids of the blood. So it aids in the acid-base balance, removes metabolic waste, drug metabolites, and excess fluid from the blood. The kidney filters 200 liters of blood per day. So imagine if there's a problem with the kidneys, that's gonna cause the waste not being removed from the body, and that can cause serious problems. It leads to renal failure, life-threatening situation. The patient, if the only way they're gonna be able to survive is they're having dialysis, or ultimately they will have to have the kidneys transplanted. But imagine all these toxic material or waste material substances will be retained by the body. They'll be kept in the blood if the renal system fails. So we have the kidney consists of a complex network of filtration system, and it produces hormones that generate new red blood cells. It plays a major role in maintaining homeostasis, and we say that's the balance, acid-base balance, ensuring that the levels are maintained with the acids and the alkaline condition of the body. Brain exerts control over urge to void. So at the end of the urinary bladder, there's a sphincter which is under the control of the autonomic nervous system, and it will dictate when you're ready to void. Now that we have looked at the anatomy and the physiology of the gastrointestinal and also the renal and urinary and genital system, we are going to be looking at the pathophysiology. Pathophysiology. What are the problems that can go? What are the issues that can happen with this system? So acute abdomen is what is referred to as a sudden onset of abdominal pain. Acute abdomen, sudden onset of abdominal pain, and it indicates peritonitis, which is the irritation of the peritoneum. And what is the peritoneum? The peritoneum is that lining of the abdomen. There are two sections to it. You have the inner lining, which covers the organs, and you have the outer lining that covers it's on the wall of the abdomen. So the wall of the abdomen lining is called the parietal peritoneum, while the lining that covers the organs is called the visceral peritoneum, similar to the parietal and visceral pleura, which is found in the chest cavity. It's the same type of situation where you have a space between both of them, and that space is used to ensure that there is minimal some reduction in friction as the organs move within the cavity. So peritonitis can be caused by infection. So once this lining become inflamed, that's what is peritonitis, and it can be caused by infection. It can be caused from penetrating abdominal wound. It can be caused from severe blunt injury, many diseases. So anything that will cause organ content, so the hollow organs, the solid organs, whatever gonna cause their content to be released in the abdominal cavity or the peritoneal space, then it will lead to peritonitis. It cause the peritoneum to be irritated or inflamed, and that is what will give the peritonitis. So we are going to be looking at symptoms. Severe pain is a major symptom of peritonitis. So all of these conditions that give rise to peritonitis, all of these conditions, you will find that common thread will be severe pain, nausea and vomiting. Those are the three main things you'll see coming out, and you will recognize other issues coming up. One second. So we said that the peritoneum consists of two membranes. I mentioned that before. And there's a partial peritoneum lines abdominal cavity, can perceive sensations. And well, I think this should be parietal. So that's the parietal peritoneum. It lines the abdominal cavity and it can perceive sensations. So there are nerves that are connected to them, and these nerves are the same nerves that come from the spinal cord and innervate the body, while the visceral peritoneum, it covers the surface of the organs and is supplied by the autonomic nervous system. So when a person is having problems with the organs, it will show up as a diffuse pain. They will not be able to identify it locally at first until it starts to affect the peritoneum. Then it picked up by the nerves that comes from the spinal cord, and you can have that localized area. They can tell you now where exactly, and you can have an idea of what structures could be affected. So visceral pain usually occurs when receptors in the hollow structures are stimulated. What we can have also is referred pain. And again, you need to recognize, we said that there are nerves ending along the body, and once the deeper nerve endings that connect to the visceral peritoneum, they can cause diffuse sensation, but it can also be picked up by the nerves that are connected to the parietal peritoneum, and they will have it felt elsewhere at points where both nerves pass each other, near to each other, and so you'd have referred pain. So a person who is having a gallbladder issue, cholecystitis, inflammation of the gallbladder, they will have that localized pain at the right upper quadrant, but they can also have pain at the right shoulder because of the referred pain, because of the connectivity or the closeness of the nerve endings from both areas of the peritoneum. And these are things that you can pick up and have an idea of what is happening. So peritonitis is typically causes ileus. And what is ileus? Normally the food is propelled through the GI tract by a process called peristalsis. So it's the rhythmic contraction of the bowels will cause the food to move forward. When there is peritonitis, it's gonna cause paralysis of the bowels. So they're gonna cease to contract. The movement's gonna be slowed almost to the point of stopping, and that is what we call ileus. So stomach can only empty itself through emesis. So once this paralysis of the bowel is not moving in the direction it should go, then the only way the stomach can empty now is to have vomiting. That's emesis. Emesis. So the person will vomit to get rid of empty that stomach. And so that's why we said most cases of peritonitis, they're gonna have abdominal pain, nausea, and vomiting associated with loss of body fluids into abdominal cavity. That's what's gonna cause the irritation and may eventually lead to hypovolemic shock. Patients with diverticulitis or cholecystitis, inflammation of the gallbladder, and diverticulitis is the inflammation of the diverticum or diverticula, is basically an outpouch in the bowel, and it's become inflamed. It may have substantial elevations in temperature. So all of these can cause is a result of the peritonitis, give rise to peritonitis. So common abdominal conditions, and you can look at this chart. So you can have appendicitis, and that's gonna be localized. You're gonna have that localized pain at the lower right quadrant, and also it can be referred to around the navel. And the patient can also have rebound tenderness. So pain felt when you after your palpate and release, it have the pain when it's released. So that's the rebound. For cholecystitis, and that we say is the inflammation of the gallbladder, we said that already. You can have the right upper quadrant pain, which is localized direct, and then you can have also have referred to the right shoulder. For ulcer, you have upper mid abdomen or upper back area. And for diverticulitis, we say it's the left lower quadrant. It can be other areas also, but most time you'll find it on the left because it's the output will come in the intestine and it covers the various quadrant, but mainly it's gonna be in the left quadrant. For abdominal aortic aneurysm, that's either rupture or dissecting, and that's the descending aorta. When it passes through the abdomen, it can either rupture or dissect, and so the patient will have low part of the back and lower quadrant pain. For cystitis, which is the inflammation of the urinary bladder, they can have that lower mid-abdomen retropubic. The urinary bladder is right behind the pubic symphysis. Kidney infection, and that's pyelonephritis. That's the inflammation of the kidney. You can have it at the costa vertebral angle. So that's right at the ribs, the lower ribs, right at that angle. And kidney stone, right or left flank, because we know the kidneys are right at the flank, so that, and it can radiate to the genitalia, which is referred, or as the kidney, as the stone move. Pelvic inflammation in women, it's gonna be both lower quadrant, as that's the fallopian tubes becoming inflamed or in that region. Pancreatitis, that's inflammation of the pancreas. You will have that pain in the upper abdomen, both quadrants and back. And pneumonia, you can have it even though it's not it's in the chest cavity, but because of the closeness and the nerves that close to each other, you can have it referred to the upper abdomen. And hernia, anywhere in the abdominal area, wherever there's a weakening area and there's a protrusion, then you will have that pain at the area. And peritonitis is when you have the peritoneum is inflamed, and it can occur all over the abdominal area. So have an idea of these conditions and where you would have that pain based on the structure and where it is located. So again, you have to know your anatomy. Causes of acute abdomen, and we said it can be a wide array of causes. Any condition that allows foreign materials into the abdominal cavity can result in peritonitis and acute abdomen. So the hollow organs can rupture, the solid organs can rupture, and the contents will be released, and eventually it will irritate the peritoneum and give rise to that acute abdomen. So retroperitoneal organs can also lead to acute abdomen. So even though they are not in the peritoneal space, but they are closely at the rear, at the posterior area, so they can also affect and cause acute abdomen. Nearly every kind of abdominal problem can cause acute abdomen. A whole range of issues, but again, assess and treat according to the presentation of the patient, and you'll be good to go. It's not our job to diagnose and find out exactly which one. We will not be able to do that. Again, we say they will have to do diagnostic tests and carry out surgical interventions eventually, where possible. For gastrointestinal hemorrhage, this is when you have bleeding within the GI tract, is a symptom of another disease, and it can be acute or chronic. So it can sudden bleeding and severe bleeding, or it can be slow bleeding that will occur over a period of time and might be there for weeks, months. So it can either be acute or chronic, and it can occur in the upper or lower GI tract. So all the organs and structures that are in that GI tract can give rise to bleeding, and it can be acute or chronic. So the first thing you can have is You can have esophagitis, and this is an inflammation of the esophagus, and it affects our irritation and swelling. And this is where you can have it caused from reflux disease, where the sphincter that control movement into the stomach can be overwhelmed, and acidic stuff comes back up and regurgitated and can cause that esophagus to be inflamed and irritated. So that's where you have gastroesophageal reflux disease, GERD. So the sphincter between the esophagus and the stomach opens, allowing stomach acid to move superiorly. So it's designed to keep fluid substance going one way towards the anus, but again, it can be overwhelmed, and pressure inside of the stomach overwhelm the sphincter, and it's like the sphincter is like a valve, and it should be going in one direction, but it can be overwhelmed and cause abdominal content to be refluxed and go in the opposite direction, which we know that it's acidic substance in the stomach, and it's not designed to be in the esophagus, so it can cause issues. Could result in weakened portions that are more susceptible to bleeding, and so it can actually cause perforation. It can eat right into the esophageal wall and actually cause an opening to be existing, and again, acidic content can be felt in the tissue surrounding the esophagus. So the main issue you have is heartburn is the predominant clinical finding, and they can have bleeding, can occur if the damage is long-term. So it can be a chronic issue, and it can also be building up until it becomes an acute issue. Another condition we can have peptic ulcer disease and gastritis. So ulcers are abrasions of the stomach or small intestine. So what happens in this case is that the acid in the stomach, it overwhelms the lining of the stomach, and so it causes erosion, and it can again cause perforation. So in peptic ulcer disease, the layer erodes, allows acid to eat into organ, usually result of Helicobacter pylori infection to the stomach, and chronic use of non-steroidal anti-inflammatory drugs. So this is what you have, you're increasing the acidity of the stomach by using these drugs, and it can overwhelm the balance that is there, and the walls of the stomach become overwhelmed and eroded. Alcohol and smoking can also affect the severity. Again, that is why we say promote good health. Peptic ulcer disease and gastritis, it affects men and women equally, more frequent in elderly, I guess because their system is more compromised already, so they will not be able to compensate readily. They will have pain, burning, gnawing, upper abdomen or below sternum. So it is basically in the stomach area, so it's gonna be upper abdomen, or it can actually be below the sternum. And the symptoms, again, we say nausea, vomiting, belching. So that's the trying to get rid of that excessive gas. Some heal without intervention. Complications can occur from bleeding. So it can heal itself if it able to compensate enough and maintain that balance and get back that. So it's able to heal itself, but if it can result in total erosion and can result in bleeding. So it can be a life-threatening condition, acute or also chronic. Another condition we can have which promote bleeding is Mallory-Weiss tear. This is where you have a tear in the junction between the esophagus and the stomach. With this tear, it's not going all the way through the esophagus, and so it's really bleeding, can promote minor bleeding or it can be severe, but it's contained within the esophagus. So primary risk factors are alcoholism, eating disorders, vomiting is a principal symptom, and you can have extent of bleeding can range from very minor to severe. I guess it depends on how bad the tear is. Another condition we can have is Borave syndrome, also occurs during vomiting, similar to Mallory-Weiss tear, but in this case, the tear is longitudinal instead of cross-sectional, and it is a tear that is entire length of the wall, so it is going to be exposing bleeding to the outside in this case. So you could say it's worse than Mallory-Weiss. These are more severe condition. So the esophagus tear is longitudinal, and the tear travels entirely through the wall of the esophagus. Unlike the Mallory tear, we say it's not going through all the wall, it's just a portion, the mucosal layer more than likely for the Mallory-Weiss. But for the Borave syndrome, it's a complete tear all the way through the layers of the esophagus, and it occurs more often in men, presents after a large meal that include alcohol consumption. Again, we see where alcohol can be dangerous. Another condition we have that can give rise to bleeding issue is esophageal varices, and these are the blood vessels we say that are surrounding the esophagus. So occur when the amount of pressure within blood vessels surrounding in the esophagus increases, and this can be as a result of problem with the liver, and it causes the backup of the blood, and so it put pressure on these vessels around the esophagus, and it can cause damage to them. So presentation takes two forms. Initially, patient shows signs of liver disease. Second presentation, rupture of varices, is far more sudden. Damage to these vessels can be life-threatening. So can be potentially life-threatening, depending on the extent of the damage to these vessels. Another condition which results in bleeding is hemorrhoids. And what are hemorrhoids? These are the blood vessels surrounding the rectum. They become swollen and inflamed, and they can bleed. This is not really life-threatening bleeding, more discomfort than anything else, pain, but may result from condition that increase pressure on the rectum. So when you're passing your stool and you're strained, you're constipated, and other issues, anything that will promote pressure on the rectum can cause hemorrhoids. So often result in bright red blood during defecation, and patient may also experience itching and a small mass on the rectum. And I think you have two types. It can have internal hemorrhoids and external. So they can be internally or they can be externally. You can have gallstones. Gallbladder stores digestive juices and waste from liver. Gallstone may form and block outlet. Again, the causes vary, but can be that there is a slow movement of the bile, and it results in stone forming, and these can cause pain. Sometimes blockage will pass. When it doesn't, cholecystitis results. So the gallbladder become inflamed because the blockage caused the bile, which should be going to emulsify the fat. It's remaining there, and it's gonna be causing inflammation of the gallbladder itself. So in severe cases, gallbladder can rupture, spreading irritation, causing spread of irritation and inflammation. Symptoms usually appear 30 minutes after a fatty meal and at night. So once you have that meal and the fat need to be emulsified, broken down, because there's no bile coming, then that person will start to exhibit these signs and symptoms, and you will have general GI distress, again, the common thread coming up, nausea, vomiting, indigestion, bloating, gas, belching. Those are the symptoms. For pancreatitis, we are looking at inflammation of the pancreas, and it forms, the purpose of the pancreas, it forms digestive juices, source of insulin, and when it's become inflamed, it causes can include obstructing gallstone, alcohol abuse. So the bile that should be coming from the gallbladder, it's become obstructed, and again we have the backup, and it causes the pancreas to be inflamed. Signs and symptoms of inflamed pancreas or pancreatitis would be severe pain, often radiating, nausea, vomiting, abdominal distension, tenderness. You can have sepsis or hemorrhage may occur. So once the content is exposed to the general abdominal cavity and it becomes systemic, it goes into the blood, then it is sepsis or sepsemia will result, and the patient will exhibit those signs of sepsis, where you then have vasodilation, hypotension. Therefore, you have to give them fluid resuscitation. Look for fever or tachycardia. Appendicitis is another issue you can have, where the appendix, which is a small recess in the large intestine, so right at the end of the small intestine, the last portion it says the ileum, once it is there's a little outcropping or outpouch right at the beginning of the large intestine, where you have collection of waste or bacteria, and if it's not being able to flush, then it will stay there and build up, and you have three conditions basically. It can be early, it can be ripe, or it can be rupture. So in the early stage, the person will start to have that diffuse pain, and as it gradually build up, it become ripe, then the pain will be more localized now because of the nerves, and the parietal peritoneum picks up that sensation, and they can tell exactly where they're having it now at the right lower quadrant, and it will continue. If it's not being able to flush, the pressure builds up until the appendix rupture, and all that content will be spread in the peritoneum, and that can abdominal cavity, and that can lead to serious life-threatening condition. So inflammation or infection in the appendix can result in an abscess, peritonitis, or shock. Signs and symptoms, we start out with dull diffuse pain, nausea, vomiting, anorexia, fever, chills, rebound tenderness, and condition worsen, then it will progress to sepsis. Gastroenteritis, and this is where it says a family of conditions. So anything that can cause bacterial or viral organism to become in the GI tract, and it's typically via contaminated food or water. So may also be caused by non-infectious conditions. So we say it's a family of condition, and it will come from contaminated water or food. So bacteria, virus, parasites, they are introduced into the alimentary canal. So the symptoms that the patient will experience are diarrhea, possibly with blood or pus, abdominal cramping, nausea and vomiting, fever, anorexia. If diarrhea continues, dehydration will result. So in order to get rid of it, the digestive process will occur faster to empty it, and so you won't have enough time to absorb the water, and so you'll have that diarrhea occurring. Another condition we can have is diverticulitis, and we say that's the inflammation of the diverticulum or diverticula, which is the outpoaching of the bowel. We have like a weakened area, like an aneurysm, and it under pressure it will be extended, and bacteria will collect in it, similar to the appendix. And once it's there collecting and not being able to be flushed, then it will give rise to pressure buildup and can become inflamed. So fiber consumption decrease. So first recognized around 1900, when the food people ate changed dramatically. So persons were not eating as much fiber and vegetable and fruits. They were eating things which are less fiber consistency, and so it gave rise to this sort of issue because of the harder work that its bowels have to do to remove these stool, and it caused pressure to build up and weaken the walls of the bowels. So fiber consumption decreased, consistency of stool became more solid, more intestinal contractions required, pressure in colon increased, and the walls become weakened and cause these outpoaching of the bowels, causing these bacteria to collect in them. So diverticulitis, bulges in colonic walls result, bulges become diverticular, fecal matter is caught, bacteria form. So the similar presentation that we see in the appendix is what we see happening here. And the signs and symptoms: abdominal pain, fever, malaise. They just don't feel well. Can't exactly tell you what's going on, but they just don't feel well. Body aches, chills, nausea, vomiting, bleeding in a rare case. Ulcerated colitis. This is again problem with the colon, caused by inflammation of the colon, cause of inflammation unclear. Genetics, stress, autoimmunity have been speculated to be responsible. Inflammation causes a thinning of the wall of the intestine, resulting in a weakened, dilated rectum. Signs and symptoms: bloody diarrhea, joint pain, skin lesion, mild to severe abdominal pain, fever, and fatigue. Irritable bowel syndrome. Patients have abdominal pain and changes in their bowel habits. Three main factors observed in patients. So they can have hypersensitivity of bowel pain receptors. They can have hyperresponsiveness of the smooth muscles in the bowel. So they can cause them to be releasing the stool quicker than normal. Psychiatric disorders, connection, and irritable bowel syndrome. Problems typically begin during childhood. Another condition we can have is Crohn's disease, in which there is a damaged area to the colon, and it can be anywhere along the alimentary tract, but can involve the entire GI tract from mouth to anus. No definitive cause has been identified. Family history and genetics play a role. So presence of signs and symptoms outside of the GI tract or GI system. Disease results in a series of attacks by the immune system and the GI tract. Pathophysiology of the urinary system. What are the problems we can have with the urinary system? And we say it's responsible for filtering the blood and maintaining the balance of acidic base. Disease conditions of the renal and urologic system can cause acute abdominal pain, and it can range from mild urinary tract infections to severe acute renal failure. So it's going to be starting from an just organism coming up via the urethra, and we say for female they are more prone because of their shortened urethra. It's gonna progress up the tract to the urinary bladder, and if it's at control, then it's gonna go past the urinary bladder, up the ureter, and reach to the kidney, where you can have acute renal failure. The kidneys now can become damaged, and so that gonna have all the waste now will be retained by the body in the blood and can have serious complications. So pre-hospital care is usually supportive. Recognizing true emergencies is critical. So it can be simple case, but it can lead to life-threatening emergencies. So urinary tract infections, commonly called UTIs, usually develop in lower urinary tract when bacteria enter the urethra and grow. More common in women, occur in upper urinary tract when lower urinary tract goes untreated. We said all of that already. Can lead to polynephritis, pyelonephritis, and abscesses. Eventually reduces kidney function. In severe cases, the more commonly in the elderly, can lead to sepsis. Again, the elderly, their systems are already compromised, and so further complications will undermine their systems more, and so they are at greater risk. Common symptoms with lower urinary tract infection: painful urination, frequent urges to urinate, difficulty in urination, pain that begins as visceral discomfort, become extreme and burning, cloudy urine with a foul odor. And this we say is when it is at the lower level, at the urethra or just approaching the urinary bladder. These are what we will see coming, are experienced by the patients. Another complication we can have with the renal system is kidney stones. So they originate in the renal pelvis, and this is where you have all the tubes or filtration system in the kidneys combine, and they exit at the renal pelvis. So that's the main collecting duct. Arise when an excess of insoluble salts or uric acid crystallize in the urine. So they form solids, and excess of salt is usually due to insufficient water intake. So when you don't drink enough water to flush the system, then it becomes too concentrated, and these salts form into crystals, and they can become solidified into kidney stones. So kidney stones calcium stones are most common, more frequent in men. Hereditary component occur in patients with metabolic hormonal disorders. So these disorders will promote the solidifying of these crystals. Patients are almost always in severe pain. Acute kidney injury. So this is sudden decrease in kidney filtration once it loses a certain percentage of its function. Sudden increase of toxins in the blood, so it's not able to filter the waste properly, and you're gonna have increase in toxins in the blood. Often reversible if diagnosed and treated early. Patient may experience edema, acid buildup, high levels of waste products in the blood. If untreated, heart failure, hypertension, metabolic acidosis. So this is where you have uremia. So the waste is retained in the blood. Chronic kidney disease. This is over a period, not unlike the acute condition where the sudden disease are progressive and irreversible inadequate kidney function. And this is where these patients will end up have to go on dialysis or eventually have to await kidney transplant. Often caused by systemic diseases, can also be caused by congenital disorders or prolonged pyelonephritis, or be secondary effect of some infection. So this is where progression of the condition, and over a period of time it reached to major damage to the kidney, and it has the filters or the tubings become constricted or lose their ability to function properly. Chronic renal failure, also the nephrons of the kidney become damaged and cease to function. Scarring occur, waste products and fluid buildup in the blood. Systemic complications can develop. So that's the danger with it. Once they are not being able to function properly, and this occur over a period of time, then the damage is permanent and it have systemic complications because all of those toxins will be retained by the blood and cause serious complications, and the result is that they will have to be dialyzed or kidney transplant. So what are the signs and symptoms we'll have when they are having this renal issue? Altered level of consciousness, seizures, coma, lethargy, nausea, headaches, cramps, signs of anemia. All of this is resulting from the toxin that are retained in the blood cause all of these malfunctions. In a patient with end-stage renal failure, so this is the result of the chronic damage to the kidney. Over a period of time, it has totally scarred and permanent damage. So they're at the end stage now. Toxic waste material build up in the patient's blood, fatal unless treated by dialysis or renal transplantation. So that's the only thing that's gonna buy them some time to be dialyzed, and we all know that's an expensive process, 2 to 3 times per week for dialysis, and can be very uncomfortable, and you know they might be awaiting renal transplantation, but ultimately a lot of them don't make it. Signs and symptoms. Initial signs, they're gonna start with confusion, shortness of breath, peripheral edema, bruising, chest pain, and bone pain. As toxins accumulate, pruritus, which is itching, nausea and vomiting, muscle twitching and tremors, and hallucinations. Pale, cool, and moist skin, edema, uremic frost, which is this they cannot excrete it, so it's they cannot excrete it via the urine, the waste, and so the waste is excreted via the skin, and so you will see this uremic frost on the skin. In the late stages, seizures and coma are possible. So this is all a result of, as we said, the buildup of toxin in the blood gonna cause these complications. Pathophysiology of the female reproductive system or organs. Gynecologic problems are a common cause of acute abdominal pain, and we see where you have the ovaries, the fallopian tubes, the uterus, and these can be impacted and cause pain in the abdomen. So always consider that a woman with a lower abdominal pain and tenderness may have a problem related to her ovaries, fallopian tubes, or uterus. And you're gonna always ask a female who is of childbearing age, when was her last menstrual cycle, because you want to rule in or rule out the possibility of pregnancy. Pain may be related to the release of an egg from an ovary as part of a normal menstrual cycle. So it can be routine as well as it can be a major issue which can be potentially life-threatening. So the patient, the female can be having pelvic inflammatory disease where the fallopian tubes and the surrounding tissues are infected and become inflamed. And so you'll have that pain in the lower quadrant and left and right. Intense pain and tenderness in lower abdomen, they can give rise to high fever. So always think the possibility of pelvic inflammatory disease, but again, we are not going to be sure. You have to diagnose exactly. You just treat what is presented, manage the ABCs. Another condition you can have is ectopic pregnancy. This is when the fertilized egg is implanted outside of the uterus, and you know it's not designed to be implanted there. Normally you'd have it along the fallopian tube, and that's not where it should be. So eventually it's gonna cause rupture, and you can have massive internal hemorrhage, acute abdominal pain generally on one side. Wherever the rupture is, if it's in the right fallopian tube, then they're gonna have it right lower pain. Again, this is a life-threatening situation if it is ruptured. For the male genital tract, we have the epididymitis and architis infection that cause inflammation of the epididymis. With architis, the infection causes one or both testes to become enlarged and tender. Swelling may occur in the groin on the affected side, and that's their lymph node or the groin itself being swollen. The testes being swollen or enlarged. The patient will have a fever and the urine will have a foul odor from the infection. Priapism is a condition that will affect the male genital tract, so it's gonna have what you call a persistent erection, and this can cause from spinal cord injury, cocaine use, blunt perineal trauma, disease such as leukemia and tumors. So it is that function that is lost or cause that persistent erection. Again, we have to be non-judgmental and maintain the patient's privacy and do not make assumptions about the cause. That's not our jobs as EMTs. We are to be advocates and for our patients and be empathic and sympathetic and do what's best for them. Again, with the male genital tract, we can have benign prostate hypertrophy. So this is enlargement of the prostate gland, and it can cause compression of the urethra which pass through it and which it enclose and are surround, and that can be asymptomatic, meaning that there is no symptoms with it, or it may lead to difficulty starting urine flow because of the compression of the urethra, and also the compression of the bladder or the sphincter area. Slow, weak urine flow once started, incomplete emptying of the bladder, increased urination at night, urinary retention. So all of these can be there, as well as it can be asymptomatic, depending on how enlarged it is. Again, there's a test that they normally do, and some persons don't want to do that test, but at the end of the day, it's better to find out before it is too late. Testicular masses rarely require pre-hospital treatment. It's painful. The pain may radiate up the spermatic cord or be localized to a specific scrotal point. Most are benign. Cystic masses are very varicocele. Testicular cancer usually presents as a painless solid lump on the testicle. So again, it can be just a simple issue, but it can become major also. Testicular torsion, this is where you have a twisting of the testicle and the spermatic cord associated with sudden onset of scrotal pain and swelling. A medical emergency if the twisting of the vessels reduces blood flow to the testes. Torsion may occur with or without blunt trauma, a testicular lump, or blood in the semen. Other organ systems. In older people, weak areas can develop in the wall of the aorta and result in aneurysm. And less acutely, dissecting is rarely associated with symptoms. If aneurysm tears or rupture, massive hemorrhage may occur with signs of acute peritoneal irritation and hemorrhagic shock. Bleeding can lead to profound shock. So always you're gonna look at the abdomen, notice if there's any pulsation. You can gently palpate it and feel if there's pulsation. This is indicative that it could be abdominal rupture of the abdominal aorta. And this is a life-threatening situation. You can also have hernia, and hernia is a protrusion of an organ or tissue through a hole in a body cavity. So there are various areas on the abdominal wall that can give rise to hernia, and we see doesn't always produce a mass or lump, and it can either be reducible, it can be strangulated, it can be incarcerated, it can be through an incision that they had from surgery. So it all depends on the situation. It can be life-threatening as well as non-life-threatening. In a reducible hernia, it can be pushed back in by itself, or you can push it back and it goes back in. If it's incarcerated, then it will not reduce by itself or by manipulation. And again, that may not be critical, but when it is strangulated, that's when it's critical. The blood vessel is gonna be affected, and that's when you can have the organ or the area appearing cyanotic. That's where the danger is. So strangulation is a serious medical emergency because, as it suggests, there compression of the blood vessels, and the tissue beyond that compression will not be oxygenated or supplied with blood, and that's a serious issue. So it's gonna need surgical intervention. Serious hernia signs and symptoms. A formerly reducible mass is no longer reducible. Pain at the hernia site, tenderness when the hernia is palpated, red or blue skin discoloration over hernia. So this is suggesting that you have hypoxia going on, and that's a serious condition. So you cannot reduce it. It used to reduce, and now it's no longer reducing. That shows that condition has worsened. And we come to patient assessment. Again, all patient assessment will start with your scene size up. We are looking at gastrointestinal and urologic emergencies. So a big focus will be on your scene safety. The potential is there for vomiting, feces, body fluids. So you must be properly covered with take your standard precautions, your gown, your mask, your eyewear, your gloves, mechanism of injury, nature of illness. So once you identify that the scene is safe, you will, and again, we can have traumatic cases also involved. So violence is possible. So always think about your scene safety. Once the scene is safe, you want to look at your mechanism of injury, nature of illness. Again, if it's indicated for spinal precaution, you will take it. You want to ensure that you adequately protected yourself and know how many patients you are dealing with. Consider your additional resources. Again, your advanced personnel. If you think the case merit that you need to call paramedic backup, you call for them. Again, it depends on your jurisdiction and your protocols. If several patients complain of GI symptoms, suspect release of biological or chemical agent. So multiple patients having the same issue, think that it could be a biological or chemical agent possible release. Once you're finished your scene size up, it's always gonna be to your primary survey and our assessment. And its common signs and symptoms of irritation or inflammation of the peritoneum will give rise to local or diffuse abdominal pain and or tenderness. Be quiet because they are guarding their abdomen. They don't want to move because movement will promote more pain. Rapid and shallow breathing, again, they're trying to guard that area from the movement, so they will be breathing shallow. Referred distant pain from the connecting nerves. Anorexia, nausea, and vomiting. Hematemesis, which is vomiting blood. Tense, often distended abdomen. All of these are what you will see are being told by the patient, and these are what is pointing in the direction of a peritonitis or inflammation of the peritoneum. So what are you going to do? At all times, we are going to be looking at getting that general impression of your patient. You want to have an idea how stable your patient appear to be from the outset. Then you're going to be looking at your LOC. If you suspect spinal injury, manual stabilization, and also you're going to go straight to your ABCDE. If there is exsanguinating bleeding, it's going to be your XABCDE. Patient experiencing renal or genital problem may exhibit many of the same symptoms as a patient with other abdominal problems. So again, there are most cases you're going to have that abdominal pain, nausea, and vomiting. You might not be sure exactly what's happening. Just provide that support of the ABCs and package patient appropriately. Location of patient can provide clues. GI problems rarely affect breathing directly. Ensure the airway is clear. If you don't have a patent airway, you don't have a patient. So don't overlook the airway and go on to bleeding, because you might notice there's a bleeding there and you get caught up with it and forget that the airway takes priority, unless we say it's an exsanguinating bleeding, or if you have the resources that you can do them simultaneously. So once you're ensured that the airway is patent, if you need to suction, you suction. If you need to turn the patient at a unit or turn them to the side and get rid of any secretion, and you have assessed their breathing, you make sure ventilation is adequate. If you need to provide assisted ventilation, you do so. And if you need to provide supplemental oxygen, you do so. You attach your pulse oximeter, you attach your monitor and get your entitled CO2 capnography reading. Listen to lung sound. Again, you can have a respiratory issue which is compromised with the gastrointestinal issue. After you have ensured that you're dealt with your airway and breathing, you're going to go to your circulatory check, and you're going to ensure that if there's any bleeding, you're going to address it. Pulse rate and quality as well as skin condition may indicate shock. Treat the patient for shock. Again, we might have potential for cardiac issue, so you connect your cardiac monitor and get your reading. Check the pulse in both arms. Again, that can indicate whether they have been a dissecting abdominal aorta issue. Many GI diseases involve pain and or hemorrhage. So shock may be caused by hypovolemia or may be the result of severe infection. Once you say there is severe infection, they're gonna lead to sepsis, and they're gonna have generalized vasodilation. Blood pressure gonna be dropping. The blood vessels gonna become permeable. That's all part of the response inflammatory reaction. So treat the patient accordingly. If you need to give fluid resuscitation, IV access, and you give fluid resuscitation up accordingly based on your protocol. Orthostatic vital signs, you need to check the patient lying down, see what it is, sitting up, see what it is, standing if possible, see what it is, and that will give you an idea on the blood loss. Assessing vital sign in two different patient positions will help you determine the extent of breathing also. take an accurate blood pressure and heart rate, and you want to get that first blood pressure check done by a manual sphygmomanometer so that you can use that as your trend. Using caution to avoid loss of consciousness, have the patient change positions and repeat measurements. Very important. Transport decision. So once you have completed your ABCs, you have check your disability, gotten your GCS, you have also done your rapid scan if it's indicated, and you're prioritizing your patient. You're going to decide, is it a load and go, stay and play? And most cases of severe abdominal pain, you don't take it lightly. So you're gonna need to take that patient in for definitive checks and care. Therefore, it's making that transport decision. Integrate information from primary assessment, rapid transport, and again with these patient population with abdominal pain, it's gonna be a gentle transport because you don't want to cause that any extra movement of the abdomen, which can worsen their condition. So patients who have airway, breathing, or circulation problems need rapid transport. Anything compromise the ABCs, that's a load and go patient. Patients with suspected internal bleeding, patient with poor general impression, ensure that the riding transport is as gentle as possible. And we know that in certain jurisdictions the roads are so rough, so take that into consideration. Pain is off once you finish your primary survey, then you're at your history taking again, and we say if the patient is conscious and oriented, you want to get your history as quick as possible because this patient can deteriorate and you will lose that opportunity. So get that as soon as possible. You are the team leader, you get the history while the partner can be doing the other parts, and you get it as quick as possible. So once you are dealing with history taking, it's always gonna be history of the chief complaint followed by your sample history, and you get your appropriate questions in based on what's happening to your patient. And it can indicate trauma. Pain is often an important finding, and we say that most cases that's what you're gonna have coming out of all these gastrointestinal emergencies. Pain, abdominal pain. So can indicate trauma, hemorrhage, infection, or obstruction. Again, it's not for us to diagnose exactly which one, but it's to manage and treat what is being presented and take your patient in where they can get that definitive care. Notify the respective facility. And we see you can look at that chart for the types of abdominal pain. So as you continue with your history taking, ensure that you get your sample history, which will give you can give you some idea and also assist the receiving facility physician with their other information. It will help elicit current and past medical history. Ask the following: did the patient vomit? They complain of nausea? Was there any change in bowel habits and urination? Weight loss, belching, flatulence? Question related to specific complaint. All of this will give you some information and clue in as to where you're heading with your field impression, or you have to have a working diagnosis, but not to say that you're directly diagnosing, but you have to have something that you're working with. If chest pain is reported, we use a pneumonic OPQRST, but the OPQRST can also help with other chief complaint, not only chest pain. You can use what you need out of it and ask the appropriate question accordingly, and it will help you. So for female, ask about last menstrual period. It's a must that you get that information. Ask about last oral intake. Again, things that they would have eaten recently might be contributing to what is happening to them. Never give anything by mouth. Again, it can cause aspiration, and also if they go for definitive care, it can affect their ability to do any surgical interventions. Check for trauma. Again, we say don't be tunnel vision. Think of the overall picture and assess and treat accordingly. Once you have completed your scene size up, primary survey or assessment, you have done your history taking, you're at your secondary assessment. As I said before, you can merge both of them as your team allow. You can be doing your history taking as a leader, and your person assistant can be doing that secondary assessment. So again, you know the systematic approach, but you deal with according to how the case present and your resources at hand. Information gathered in the history taking may be used to focus your physical examination of the abdomen. Pain and tenderness are most common symptoms of an acute abdomen. Patient with peritonitis usually has abdominal pain. So once you are going to focus, depending on the condition of your patient, you're gonna focus on the area of concern. Once you're gonna palpate that abdomen, always start at the quadrant that is away from the area that you have in the pain, and you move towards that area last. So the patient, if you go there first, they can start guarding the process, and you will not be able to get a true assessment of that abdomen. Again, you will explain assessment procedures, expose and assess abdomen, and remember you're gonna recover when you're finished. Palpate the abdomen very gently. Look for patient response. High respiratory rate, normal pulse, high blood pressure may indicate improper ventilations. High respiratory rate, pulse rate with signs of shock may indicate septic hypovolemic shock. When available, use pulse oximetry, non-invasive blood pressure devices, and also your end-tidal CO2 capnography reading will help in this respect. Again, we say these patients with abdominal pain will guard and not want to breathe as deeply because it will help to lessen the pain. Frequent, so once you have completed your, and you, again, we always remember that a part of your secondary assessment will be your vital signs. Very important, using all your monitoring devices to get your vital signs, so you can use it as a part of your reassessment also. So once you have completed your scene size up, primary survey or assessment, history taking along with your secondary assessment, then you are at the end of the patient assessment where you're gonna reassess. So you'd have called into the receiving facility, inform them of what you're coming in with so that they can prepare for whatever issue they need to get ready for, and you would have been monitoring your patient en route to the receiving facility. A patient who is unstable, every 5 minutes you should be doing that reassessment. Stable patient, at least every 15 minutes you should be reassessing. And what are you going to reassess? It's basically going over what you had done before, going back to your ABCs, LOC, ABCs, chief complaint, vital signs, interventions, all those things, and any changes, you deal with it. If you find any new problem, deal with it. Anything not working, fix it. So reassess the patient and then ask and answer the appropriate questions. If the patient has GI bleeding, continue to assess for signs of shock. Call for a paramedic backup if the patient's condition becomes unstable. And from the outset, if you suspect the case may reach to that, you would have called for the backup already. Better to call early than call too late. And also, remember, you would have given the patient oxygen. Don't tell yourself that the tank is still flowing with oxygen. The tank could have run out and you are there assuming that oxygen is flowing. So check back on that tank, make sure it still have oxygen in there. Emergency medical care as it relates to these gastrointestinal problems for acute abdomen is a serious medical or surgical emergency. Provide prompt, gentle transport, do not delay. So all acute abdomen, once the person is having severe abdominal pain, we cannot tell ourselves that is a simple case. We don't know for sure. Always gonna err on the side of caution, provide that supportive care, support the ABCs, transport gentle because organs can be impacted and we don't want to cause further damage. So gentle transport, do not delay. They need to get to the place where they can diagnose and provide the care that they need. Before transport, do not attempt to diagnose the cause. We say that the causes can be so wide and varied. It's not our job to be trying to find out what is the exact cause. Treat what is presented, package appropriately, transport appropriately. Clear and manage the airway. That's important. We have to do. Make sure that they have a patent airway. We have to anticipate vomiting. Remember, we said that almost all of the abdominal issue, gastrointestinal issue, possibly involve vomiting. So be mindful of that. Administer 100% supplemental oxygen if it's needed. If you need to provide assisted ventilation, do so. Give nothing by mouth. Document all pertinent information. Anticipate and treat hypovolemic shock. Establish IV access and maintain fluid. Follow your protocol. We say that the patient can also have issues with cardiac related issues. Connect your cardiac monitor and make sure you monitor them in that way. And don't forget your end-tidal CO2 capnography reading. Before transport, make the patient as comfortable as possible. Monitor vital signs which may change quickly. Consider calling for paramedic backup. For pelvic inflammatory disease, pain may be intense and accompanied by a high fever. Transport patient to ED immediately. Again, we say we are not sure if it's a PID or ectopic pregnancy because we most of the time cannot differentiate. So always gonna consider the worst. Consider ectopic pregnancy in females of childbearing age who present with acute abdominal distress, especially in the presence of hypotension. Pneumonia may cause both ileus and abdominal pain. We say it's related to the respiratory system, which would be associated with the chest cavity. But again, because of the closeness of the cavities, you can have that response where it affects and the esophagus pass through the chest cavity. So it can be affected and result in ileus, which is paralysis of the bowels, and abdominal pain. Inflammatory response affect the abdomen. Treat transport as you would any other patient with abdominal pain. Just to point out also, patients having certain condition will also have chest pain and we might be associated strictly to the gastrointestinal system, but be mindful also that it could be a cardiac related incident. Again, we say you would have connected your cardiac monitor and then you can take it from there. Acute signs and symptoms with shock could signify an aneurysm, requires prompt transportation, avoid unnecessary and vigorous palpation of the abdomen. So you don't want to have a abdominal aortic rupture and you're vigorously palpating and it matters worse. With a hernia, transport promptly to the emergency department. Again, we say it can be simple, reducible, can be incarcerated, strangulated is the critical one. For acute kidney inflammation and infection and chronic kidney disease can lead to life-threatening emergencies. Support of ABCs is imperative. Be alert for a possibility of hypotension or pulmonary edema. Provide emergent transport and supportive care. Again, we cannot be sure whether it's just a simple issue or not. Support the ABCs and transport. Only definitive treatment for end-stage renal failure is renal dialysis, and also eventually they will need to get kidney transplant. But the thing that's gonna buy them some time is that renal dialysis. They need to be dialyzed, and they have two types. So you're gonna have peritoneal dialysis and hemodialysis. Hemodialysis is the most popular one, where their blood is actually, they're connected to a machine and the blood is actually passed through the machine, and the machine is gonna do what the kidney should be doing, filtering that blood, and that is sent back into the patient. For the peritoneal dialysis, they will place fluids into the abdomen, and it will remain there for a couple hours, and that in effect will do what the kidney should be doing, filter the blood, and then it is removed. So patient's blood is filtered and cleansed of the toxins, normalizes the blood chemistry. So that's what it is doing, artificially doing what the kidney should be doing. Adverse effects and complications. It can lead to hypotension, muscle cramps, nausea and vomiting, hemorrhage from access site, infection at access site, altered mentation, loss of consciousness, embolism, electrolyte imbalance, myocardial ischemia. All of these are complications when a person is being dialyzed, and you might be called to the dialysis center where the patient is, because they have, some of them might code on them, and they need you to come and take them from there. So be mindful of that. It can be, they can have hemorrhaging at the site. They can have ear embolism. Ear is introduced into the circulation from the exposed ear, and they can have myocardial ischemia. These are some conditions. They can move from confused to total loss of consciousness. Infection at the site is possible. These are all adverse effects, but at the end of the day, it is what is gonna buy them some time. Without this dialysis, they don't stand a chance until they can get a renal kidney transplant, and that's not, before a lot of them can get that transplant, they don't make it, they die. Sudden drop in blood pressure is not uncommon during or immediately after. If not promptly treated, cardiac arrest is possible. If patient misses a dialysis treatment, weakness, pulmonary edema, or excess of electrolytes may occur. So if they miss a treatment, then they're gonna have excess toxin in the blood, and that is gonna give rise to the weakness, and can have pulmonary edema, and excess of electrolytes may occur. Very serious issue. If call involves patient receiving dialysis, start with ABCs. Be alert for leaking shunts. Many dialysis patients also have urinary catheters. Make all attempts to deliver the patient to a hospital with dialysis capabilities. So once you are called to these patients, follow your patient assessment, go through your scene size up. You basically assume that scene might be safe, but do your checks, and you go to your XABC and take it from there. DE. Be alert for leaking shunts. Disequilibrium syndrome. So water initially shifts from the bloodstream into the CSF, mildly increasing intracranial pressure, characterized by nausea, vomiting, headache, and confusion. After a few hours, the fluid will re-equilibrate between the blood and CSF, and the patient's symptoms will improve on their own. So this is a complication you can also have from renal dialysis, but normal body process will restore it, but and as we look at the last slide for gastrointestinal emergencies and urologic emergencies, with dialysis we said the possibility of ear embolism. If any of the fittings and connections in the dialysis system are loose, ear may enter the system, producing an ear embolism. Symptoms include sudden dyspnea, hypotension, and cyanosis. Disconnect the patient from a dialysis machine and manage appropriately. So it depends on where that ear embolism has reached. You will have to recognize it can be a heart issue, can be brain issue, treat the patient accordingly. But first get them disconnected from the machine. And that brings us to the end of the gastrointestinal urologic emergency chapter. Any questions? Any questions? Everything clear, Mr. Brown?
Yes, sir.
Miss
No, that's
McLeod,
okay, but
are you clear, Miss McLeod? Oh, look like Miss McLeod is inactive. Mr. Bradshaw, what's the difference between the visceral and the parietal peritoneum?
right, the visceral is on inside of the organ, while the parietal is on outside.
When you say inside the organ, that's not clear. The visceral
No, closer to the
peritoneum
organ.
is. Say that again.
The one that is closer to the organ.
Okay. So it covers the organs while the parietal attaches to the abdominal wall. Okay. No questions?
Just hold on, I
Everything
was
is
looking
clear?
at No, I wrote down a question to ask. I was just looking for that part. Just give me a minute.
Okay.
Right, you can just explain back over the Mallory's tear and the Occipital symptom.
The Mallory's tear and the which symptom?
One that started B Walker vein symptom.
Okay. So Mallory's tear is where we said at the junction between the esophagus and the stomach has a tear, but the tear is not total tearing of the esophagus. It's just through the mucosal layer, which is the inner layer of the esophagus. So it will cause bleeding to the inside, and that's not a very serious bleeding. But unlike the Mallory's wheeze tear, the Boreve syndrome is where you have a tear in the esophagus, but it's a longitudinal tear and it goes all the way through all the layers of the esophagus. So you're gonna have bleeding to the outside of the esophagus, and that's a more life-threatening, more severe bleeding. So that's the difference with them. So both of them has bleeding and can be life-threatening, but you would consider the Boreve syndrome as a more serious one, and because the fact that it's gone all the way through the esophagus and it's potential bleeding on the outside, and contents will be on the outside, so more possibility of infection, and you'll have a more wider range of symptoms. Understand?
Yeah, understood.
Okay. Again, we won't be able to differentiate that very much in the field. So again, it's manage what is presented and treat ABCs, package your patient appropriately, and you'll have to take them in where they can do further diagnosing and do the definitive care for that patient. Any other questions? Okay, if no more questions, then we will close off for now. Mr. Rufus, are you still there? Okay, so we'll close off for today, and you'll follow as it is for tomorrow, and ensure that you continue to reread and prepare your material for the next day, and you should be good to go. You can always reach out if there's anything you're not sure of. Okay.